Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is Cardiology Board EKG Interpretation. On our YouTube channel, we have more than 300 cardiology lectures, starting with basic science all the way up to 2022 ACC AHA guidelines. We would like you to watch them. At the end of this presentation, I'm going to tell you how you can get a free copy of my cardiology rotations manual with the valuable information that is useful at bedside, either in a hospital or in a clinic setup or in an emergency room. I also have an EKG book which I have written, and I have videos on every chapter of this book on my YouTube channel. You can watch them. So let us begin with the feature presentation, that is Cardiology Board EKG Interpretations, and the section is going to be on myocardial infarction, recent and old. For those who are taking cardiology boards, you may be familiar with the answer key that is provided to you to mark the EKG changes that you notice in the EKG section of the cardiology boards. And this is the template which I have going to be using, and I have prepared an overall presentation on this template along with separate sections, separate videos for each one of these segments. I would like to invite you to watch those segments. And in this presentation, we're going to be talking about the myocardial infarction, the location, and the age of the myocardial infarction, whether it is recent or probably old. And in the following videos, I'll be doing a segment on STT and U-wave abnormalities and a separate video on pacemaker function. So let us begin with the feature presentation. That is, we are going to be focusing on myocardial infarction and the location of the myocardial infarction. As you can see, there's only 1, 2, 3, 4, 5 areas that you need to be familiar with as far as whether they are recent or old in terms of age. Before we go into the location of the myocardial infarction, we need to understand the coronary anatomy behind the classification of the myocardial infarction. As you know, the heart is supplied by two main coronary arteries, the left main coronary artery and the right coronary artery. The left main coronary artery divides into the left anterior descending branch, which is one of the most important branches, which divides into the diagonal branches that supply the high anterior wall, whereas the main trunk of the left anterior descending artery and the septal branches supply the anteroseptal area. So an occlusion of the left anterior descending artery beyond the first diagonal branch may result in an anteroseptal myocardial infarction. Whereas if you have a proximal left anterior descending artery occluded before it divides into any branches, it not only involves the anteroseptal area, it can also involve the high anterior and also the lateral wall, that is the anterolateral region of the heart. On the other hand, we have the circumflex branch, which wraps around the left atrioventricular groove and gives rise to the marginal branches which supply primarily the lateral wall of the left ventricle, and that's where we get the anterolateral myocardial infarction if we have an occlusion of one of the marginal branches, or it can also be related to the occlusion of the LAD with the diagonal branches supplying the anterolateral region. Lateral infarct is primarily caused by occlusion of one of the marginal branches that results in changes in the lateral chest leads, namely V5, V6. On the other side, we have the right coronary artery, which arises from the right coronary cusps, and it gives rise to the right ventricular branches, which may be occasionally involved in the right ventricular infarction, which is not mentioned here, so we don't need to worry about it. Anyway, the right coronary artery gives rise to the posterior descending branch, which supplies the inferior wall. So if we see changes in the inferior wall, then we are talking about occlusion of the right coronary artery in 85% of the cases. And in 15% of the cases, the posterior descending branch is supplied by the circumflex trunk. In that case, it may be the circumflex trunk distal branches that may be occluded. In addition to that, the circumflex margines also supply the posterior wall of the left ventricle, and it can also be supplied by the posterolateral branch of the right coronary artery. So the posterior infarction can be related to occlusion of the distal right coronary artery, in which case we can see an inferior myocardial infarction and also a posterior wall involvement, or it could be from the circumflex distal branches which supply the posterior wall of the ventricle and also the inferior wall in about 15% of the patients. This is a little diagram which I created more than 30 years ago. So the basic physiology of myocardial infarction does not change. The basic science does not change. And that's an important thing to understand, that here is a normal electrocardiogram with a P wave, then we have a PR interval, then we have the QRS, then we have the ST segment, the J point, and an upright T wave. This is the normal configuration of a beat, except in case of AVR, where everything is a mirror image of this one. In case of an acute myocardial infarction, let's talk about an acute occlusion of a branch of a coronary artery. The first thing that we will notice is the straightening of the ST segment, which is rarely ever talked about. This is something which Marriott, who used to describe these early changes on the electrocardiogram, because in those days, electrocardiogram was the standard for diagnosing myocardial infarction. Anyway, the straightening of the ST segment is then followed by lifting of the J point, that is leading to the ST elevation and hyperacute T waves, similar to the T waves that we may see in patients with hyperkalemia. Over a period of several hours, the ST segment becomes upwardly convex with an inverted T wave, and within 6 to 8 hours, the heart loses the R wave amplitude, which is replaced by a QS complex. We need to understand some of the important features of the QS complex in order to diagnose myocardial infarction. The QS complex has to be more than 40 milliseconds or 1 box. And in case of old myocardial infarctions, the Q waves have to be at least 25% of the R waves. By 6 hours or so, we see the development of Q waves. That's why if you are seeing a patient in the emergency room with a vague chest pain, which had been going on for like 10-12 hours, you always look for any changes that may suggest that the development of Q waves already in the electrocardiogram. Then over a period of several days, maybe anywhere from a week or 2 weeks, the R wave is completely replaced by QS complex. The ST segments gradually come down. They still remain convex with a T wave inversion. And after about 6 weeks or so, the ST segments become flat and the T waves may become upright. However, the T waves can remain inverted for up to 6 months or longer. In case of an old myocardial infarction, the changes that persist are the Q waves. It could be just QS complex, or in about 15 to 20% of the patients, there may be regeneration of this R wave. As a result, we're going to see QR complex, in which case the Q waves have to be more than 40 milliseconds, because sometimes we can see Q waves because of the activation of the septum, but those are tiny Q waves as we see here. So those are different from the pathological Q waves, which are more than 40 milliseconds plus at least 25% of the R waves. and the T wave should be generally upright in an old myocardial infarction. And there are conditions where patients can have EKG changes and also possible elevation of cardiac biomarkers like troponin. And one such condition is ST depression and T wave inversion, which may be associated with or without the elevation of troponins. If there is no elevation of troponins, this is considered as a subendocardial ischemia, which may be persistent for long periods of time, or it may be acute in nature, which may be related to subendocardial myocardial infarction. Similarly, we can see diffuse T wave changes, symmetrically inverted T wave changes in multiple leads, which may suggest myocardial ischemia, or it may be throughout the entire electrocardiogram, in which case it may suggest global myocardial ischemia. If it is related to certain groups of leads and is associated with elevated troponins, it is considered non-transmural myocardial infarction. Both these cases are both cases it is non-transmural myocardial infarction. Here it's a little more obvious because of the ST depression, and in this case we just see T wave changes. So these are the evolutionary changes related to acute myocardial infarction, subendocardial ischemia or infarction, and myocardial ischemia. So let us proceed with, now looking at this chart, you should be able to diagnose everything that is asked for in the cardiology boards. The high anterior myocardial infarction usually is related to occlusion of a diagonal branch, which is reflected in lead 1 and AVL. Anteroseptal myocardial infarction is also related to the left anterior descending artery occlusion, which is reflected in leads V1, V2, V3, and V4. The lateral myocardial infarction it may be related to the left anterior descending or the circumflex marginal branches, and it is usually reflected in V5 and V6. Anterolateral myocardial infarction, the terminology is sometimes confusing because different textbooks use different nomenclature to describe anterolateral myocardial infarction. Some textbooks describe the anterolateral myocardial infarction as the one involving lead 1, AVL, and V4 to V6. That is high anterior and the lateral wall, which again is related to the left anterior descending branch. And sometimes we have extensive anterior or anterolateral myocardial infarction, which can involve 1 AVL and like V2 to V6. So if that's the case, that's the extensive anterolateral myocardial infarction. We don't need to worry about it because that's not on the table that we just saw here. It's not on this table. So I would just focus on anterolateral, which is represented by 1 AVL and the lateral chest leads, namely V4 to V6, and anterior is, or anteroseptal is V1 to V4. Lateral is, of course, V5, V6. Inferior is 2, 3 AVF, inferior myocardial infarction, 2, 3 AVF. Infraepical is, again, it's not listed there, but for your purpose, I'm just telling you, sometimes you can see inferior wall changes and also similar changes in V3 and V4, which is considered as infraepical because in a small percentage of people, the infraepical region of the tip of the heart is supplied by the distal branches of the posterior descending artery coming from the right coronary artery. The posterior myocardial infarction can be either from the right coronary artery or the circumflex branch, and that is usually related to the infarction involving the posterior wall of the left ventricle, which is situated behind the sternum, and we see mirror image reflections in lead V1 to V3, that is ST elevation and upright T waves in these leads where you don't expect to see them normally. We're going to look at actual examples of these. So let's get familiar with these regions: anterolateral, anteroseptal, lateral, inferior, posterior. The second question comes up as, is this acute or is this old? This can be easily ascertained by looking at this chart which I have shown you. Well, you need to imprint this image in your mind and your brain so that when you look at an electrocardiogram, you should be immediately able to locate the location of the myocardial infarction and the age of the myocardial infarction, whether it is like less than 6 hours or more than 6 hours or more than 6 months, and if it's like an old infarct. If you look at the echocardiogram, it gives you a visualization of what we are talking about. Here we have the anterior wall, which is usually reflected in V1 and V2. When you have the anteroseptal region, the anterior and the septum, we have V1 to V4. We have the lateral wall, which is usually reflected in 1 and AVL plus V5 and V6. Then, in fact, inferior wall, which is reflected in the leads 2, 3, and AVF. Somehow, the anatomy of the echocardiogram and the surface electrocardiogram don't exactly match, but that's the reality. Okay, let us look at some examples now. And here we see ST elevation. This is in a hyperacute phase of a myocardial infarction, which I just showed you a couple of slides ago. We have the ST segment elevation, the straightening of the ST segment, and lifting of the T waves. So this is an acute myocardial infarction. There is already the presence of a Q wave, but this Q wave is not quite meeting the requirements of the pathological Q wave which I was talking about. So we are talking about a myocardial infarction that is less than 6 hours. We don't need to about that as long as we can recognize this as a recent myocardial infarction. The next item we need to look at is what are the regions that are involved here. We have the inferior region as it is seen in lead 2, 3, and AVF. And along with that, we also have the lateral chest leads, which also show, of course, the development of Q waves and ST segment elevation and a T wave inversion. So we have inferolateral myocardial infarction. If this patient were to be taken to the cardiac catheterization lab, because of the involvement of the lateral wall and the inferior wall, you would expect to see an occlusion most likely involving the circumflex branch as opposed to the right coronary artery, as right coronary artery rarely supplies the lateral wall of the left ventricle. The ST depression and T wave prominent R waves may also suggest the development of posterior wall involvement. Since we already have lateral wall involvement, these prominent R waves make you think that you're looking at infraposterior and lateral recent myocardial infarction. Of course, you're not going to get this complex EKG, but when we start off with the very complex EKG, then it should be easier as we go further. In the anterolateral leads, in the high anterior leads, lead 1 and AVL, we see reciprocal T wave changes. And here is an example of a sinus rhythm along with the T wave inversions. Symmetrically inverted T waves in the absence of left ventricular hypertrophy. Otherwise, these could be secondary repolarization abnormalities related to the hypertrophy. So if this person were to come with an acute chest pain with these T wave changes, you're talking about left ventricular ischemia. If this is associated with enzyme elevations, then you are looking at like non-transmural myocardial infarction. That's a terminology that's used for patients with T wave changes and elevated troponin levels. It is actually involving the anterolateral region because we have lead 1, AVL, and V4 to V6. So this is the anterolateral region of the left ventricle. So that's what we would mark. And this is, of course, you're not going to mark here because this is mainly we are seeing T wave changes. There's no ST elevation. There's no loss of R waves. So this is just ventricular ischemia or non-transmural myocardial infarction. Here we have an example of what looks like some changes seen in the anteroseptal region, V1 to V3 or V4. If depending on lead placement. Here we have loss of R wave, and there's also this R wave is quite diminished compared to this R wave. Along with that, we have ST elevation, straightening of the ST segment, and hyperacute T waves. So this is an anteroseptal myocardial infarction. Then we see some reciprocal changes. These are known as the reciprocal changes, where we see some ST depression that is sort of a reflection of what we see here anteriorly. So this is a recent anteroseptal myocardial infarction. And here's an example of lead 1, ABL, V2 to V6. This is an anterolateral recent myocardial infarction associated with some reciprocal changes in lead 3 and AVF. When I was doing fellowship, I was introduced to these changes as tombstone T waves. And these are usually related to occlusion of the proximal left anterior descending artery before it gives rise to the septal and diagonal branches, which results in this extensive anterolateral myocardial infarction. And in those days, where we didn't have thrombolytics or acute coronary intervention, the mortality was pretty high. Today, even when patients present with these kind of changes, if they are taken to the cardiac catheterization lab within the first 60 minutes or so, and we can successfully open the artery, we can salvage a significant amount of myocardium. And that is the progress that we have made in the past 2-3 decades. Here is an example of a ST elevation, straightening of the ST segment I was talking to you, with the lifting of the J point and hyperacute changes seen in lead 1, ABL, V1, V2, V3, V4. So anteroseptal and high anterior. So you could say this is the proximal left anterior descending artery, which involves the diagonal branch which supplies this high anterior wall, which is reflected in 1 and AVL. And also we have the anteroseptal region with the reciprocal changes. Sometimes we see right ventricular infarction. If we are dealing with a proximal right coronary artery occlusion, the right acute marginal branches supplying the right ventricle may also get occluded. That can lead to the right ventricular infarction. The regular electrocardiograms may not show the presence of right ventricular infarction. However, if we do the right-sided chest leads, like if you put the leads on the right side of the chest, then we can see this ST elevation and T wave inversion along with the loss of R waves, and that may signify the presence of right ventricular infarction. So clinically speaking, this is beyond just the EKG test, but when you're taking a cardiology exam, you're doing tested for everything in other segments. If you have an inferior wall infarction and a patient is hypotensive, always think about the presence of right ventricular infarction, which can be sort of confirmed by the right chest leads or by echocardiogram for that matter. Okay, here we have, what do we have here? We've got a sinus rhythm, and we have tall R waves here, which are uncommon. Now we have the ST depression and an upright T wave. This is like a mirror image of what we would expect to see in expect to see in a posterior myocardial infarction. Along with that, we also have some ST elevation in the lateral chest leads. So this is an infarct involving the lateral wall and the posterior wall, which is probably related to the distal circumflex branch, marginal, and the posterior lateral branch coming from the circumflex trunk supplying the posterior wall. Of course, you're not going to see these kind of complex EKGs, hopefully, in the cardiology board exam, but I'm just telling you how you need to look for everything that is visible on the electrocardiogram. Here we have an acute phase of lateral myocardial infarction, which immediately should make us think that we are dealing with a circumflex branch. And if it's a circumflex trunk, it's not unreasonable to see if there are if there's involvement of the posterior wall, and this is what is reflected here with tall R waves and ST depression. In this example, we have a diffuse ST segment depression of almost 2 millimeters, horizontal ST depression of 2 to 3 millimeters in the leads V3 to V6, and also to some degree in lead 2. So this is subendocardial ischemia, and if the patient has chest pain and elevated troponin levels, this is suggestive of a subendocardial myocardial infarction. Of course, this comes in the following segment after the myocardial infarction, which is titled STT abnormalities. So we are covering that segment also in this, which is good. So whenever you see horizontal ST depression in multiple leads or groups of leads, and if the patient presents with chest pain, consider subendocardial ischemia or infarction if it is associated with elevated biomarkers like troponin. Here we are looking at an electrocardiogram that has significant voltage in 1 AVL along with voltage S and R wave combined together, which suggests left ventricular hypertrophy with strain. However, there are some T-wave inversions in the inferior leads which are not usually associated with left ventricular hypertrophy with strain. So this is left ventricular hypertrophy with strain with some T-wave changes suggestive of ischemia in the inferior leads. If this patient were to come with a history of chest pain, you have to suggest that there's not only left ventricular hypertrophy with strain, but also some ischemic changes in the inferior leads. And here's another example of diffuse, deeply inverted T waves, which is suggestive in the inferior and lateral leads in the absence of any evidence for left ventricular hypertrophy. So this is what you would consider as left ventricular ischemia, which is involving a large segment of the myocardium, with the exception of lead 1 and AVL. Almost all the other leads have a T-wave inversion, which are deeply symmetrical. Here's another example of giant T-wave inversion noted in 2, 3, AVF, V1 to V6, along with incomplete right bundle branch block. We have a sinus rhythm with perhaps maybe even some degree of right axis deviation, right bundle branch block, giant T-wave inversions. And whenever we see this, we always need to think about the cerebrovascular accident, which is associated with giant negative T-waves. But along with that, we also have loss of R waves anteriorly here, or QS complexes, which suggests an anteroseptal myocardial. V1 to V4, we have loss of R waves, anteroseptal myocardial infarction. Again, it depends upon the history if the person is having, but these changes may be suggestive of cerebrovascular accident or a recent anteroseptal myocardial infarction associated with global left ventricular ischemia. Here we have an example of lead 1, AVL, already pathological QAs here in V2 with ST elevation and ST elevation seen in, so we have anterolateral myocardial infarction involving 1 AVL, V2 to V6. So this is an extensive anterolateral myocardial infarction, and it is usually related to the occlusion of the proximal left anterior descending branch. And we see reciprocal changes that are reflected here as ST depression in lead 3 and AVF. Here we have an example of a hyperacute phase of an acute myocardial infarction in the high anterior region, as it is seen in lead 1 and AVL. Along with lateral leads, there is some ST elevation and hyperacute T waves noted here. So this is an anterolateral myocardial infarction, whereas the anteroseptal region looks okay here. Then we have some reciprocal changes noted in lead 3 and AVF. The main thing is Whenever we see J point elevation, straightening of the ST segment, and hyperacute T waves, those are the primary changes of an acute myocardial infarction. And the changes we see in the leads directly opposite to them are secondary changes. Here's another example which is similar to the one we saw. Lead 1, AVL, has hyperacute changes with loss of airways, significant loss of airways, and we also have, this is like a very extensive anterolateral, anteroseptal and lateral myocardial infarction. This is most likely related to very proximal occlusion of the left anterior descending artery, which is involving a significant amount of the myocardium. And here is an example of tall R waves here with ST depression and upright T waves. And when we see this ST depression, tall R waves and upright T waves, this is a mirror image of what we see here, like in these, like ST elevation and upright T waves. And this is similar to what we see here. And this is a reflection of the posterior infarct seen in the anterior chest leads. It is usually related to occlusion of the posterolateral branch of the right coronary artery or the distal branches of the circumflex trunk supplying the posterior wall. We don't see much changes in the inferior wall or the lateral chest leads, so it is predominantly seen in the leads V2 and V3, and whenever you see this one, you need to consider posterior myocardial infarction. In fact, in one of those answer key sheets, the posterior myocardial infarction is listed, and this is an image that you need to remember. If they present something like this, possibly consider posterior myocardial infarction, and this is acute because the ST segment and T wave changes are acute in nature. Here is an example of some loss of airways, ST depression, and T wave, which is biphasic in lead 2, 3, and 4. So this is an anteroseptal subendocardial ischemia or infarction. Troponin is elevated, it is subendocardial infarction. If it's not associated with elevated troponins, it is considered as subendocardial ischemia. Whereas T wave inversion is suggestive of just left ventricular ischemia. So, ladies and gentlemen, this is a very quick overview of acute myocardial infarction, the coronary anatomy, the location of the myocardial infarction, the leads that represent the given anatomy of occlusion, along with the EKG changes that are related to hyperacute phase or an old myocardial infarction. Always remember, in order to diagnose a myocardial infarction, we have to see changes in at least 2 or more leads. So the way to get a copy of this cardiology rotation manual is just send me an email to Dr. Nik Nikam, and please let us know where you're located and what is your specialty and how this book would help you in your clinical practice. Thank you so much for watching this presentation. I am Dr. Nik Nikam, and this is Triple N Media, and we will see you in the next presentation.